Cardia, Hearts and Sciences, your opportunity to see the latest in how heart care is performed, and you'll never see it like this anywhere else because we have unprecedented access from the patients, the doctors, and the staff at Prairie Heart Institute at St. John's. And the Dean of the School of Hearts and Sciences, Dr. Greg Mischkel, my cardiologist, by the way. So,
I see you infrequently.
Infrequently,
You don't
that's
return my
it.
phone
At least
calls.
for now. At least for now. Thanks for being here, and you brought a really terrific guest with you. You do some structural work. You're an interventional cardiologist, and you do some what we call structural work.
Correct.
And you brought a colleague along who does the same thing.
Correct. So I'd like to introduce, you know Nilesh Goswami very well. Nilesh is the director of our cath lab and one of the accomplished interventional cardiologists within our group, and somebody who's similarly and likewise dedicated himself to this new field of cardiovascular medicine called structural heart disease. Why don't you, Nilesh, talk a little bit about what we mean by structural heart disease and who gets involved in it?
Right. So typically it's, I would say, a sub-branch or subspecialty of interventional cardiology. And so interventional cardiologists, going back or stepping back a little bit, are cardiologists that perform procedures, typically stents, start off with stents in the heart, and then we've grown from stents in the heart to stents outside the heart, so in the legs or in the carotid arteries, and fixing aneurysms, and now we've evolved to include structural heart disease under that subspecialty as well. And so that includes valvular heart disease. So if there's a valve problem, we can either replace the valve or even repair the valve you currently have through catheters from either the arm or the leg. If there's a hole in the heart, we can repair that. If there's an area of the heart we'd like to close off or get rid of, we can take care of that as well, all through non-surgical techniques or catheter-based techniques through the leg.
And one of the other interesting aspects of structural heart disease, it really represents a coalescence of what was previously two exactly opposite specialties, cardiologists and surgeons, because in fact, these procedures, the valve replacements, we do in conjunction with our surgical colleagues. So we're working cheek by jowl, side by side in the cath lab with a cardiac surgeon to replace these valves.
You've always liked to joke that there are really two types of cardiologists. You know, there's two unions, the plumbers and the electricians, right? But the people that are involved in the structural elements like you guys are, do they mostly come from the plumbing side, or how does that?
I think so, but I think it's a whole new specialty. I'd call them carpenters. So now we have three unions, carpenters, plumbers, and electricians.
And some of this involves asbestos removal, I think, doesn't it?
Uh-oh.
Maybe more dangerous.
More dangerous than we expected.
Okay, and what we're seeing is this whole field is really mushrooming because, like you say, you're replacing valves now, and you're doing, and if you can put a stent in a coronary artery, for instance, why not put it in a carotid artery or in a leg artery? And those things are all things that cardiologists can now do.
Correct. But I think the biggest challenge and one of the most gratifying things is the ability to get a valve into the heart. I mean, and people say, well, oh my God, how can you possibly, through a small incision in the groin, get a valve into the heart? And it's really kind of remarkable technology. In fact, we have some valves here on the table. I'll just show you some of the earliest versions here. These are two of the earliest versions, what we call ball and cage valves. And you can imagine trying to put this valve, this is old-fashioned already, but this is one of the original valves, where the blood would push the ball up against the cage, blood would escape from the heart, and then the ball would pop down and seal the valve
So that would
up.
have to do that frequently,
Every heartbeat.
Yeah,
And that's what
okay.
we used to, or the surgeons used to put in. But now we are able to insert a valve like this. And Nilesh, you want to explain what this valve is? This is the valve we actually put in through the groin.
Right, so this is kind of a latest iteration of this valve, and essentially it is a stent, which is a metal cage type of device that can be expanded and compressed. And inside the stent has been sewn specially prepared animal tissue, and each one of those is a leaflet.
Those
so
are leaflets, okay, and
yeah.
I thought those were solid, but they're soft.
No, they're very soft. So this is what opens and closes, and this is very similar to the design of our own aortic valve.
Well, let's take a look at this first clip, because what we're going to see is what you call a TAVR procedure, and there's the surgeon you're talking about.
Well, that's Dr. Stevens.
And you have a surgeon in those in case something goes wrong.
Well,
at least you're prepared to go in.
And more than that, they're integral parts of the team, and so we scrub and we share the procedure, and depending on circumstances, he or I might be pushing the valve, pulling the valve, whatever.
And I think an important point to make as well is they're not just there for the procedure, but they're helping us make the decision before the procedure. So we have them see the patient as well as us, and jointly we make a decision as to who would benefit most from this type of valve.
Now you have a sonogram in this procedure too. Is I can see the red, the red colors on the
Right.
heart.
So that's what's called a transesophageal echo, where
Okay.
we're looking at the heart. Now, what's happening here is we're taking this catheter. In fact, I've got one if you want to take a look at
Okay.
it, Mark. We take this. I just happen to have one here in my pocket.
Careful, careful.
I have large pockets. Nilesh, why don't you describe how we put this valve onto that catheter?
Right, so the valve essentially is crimped onto this valve delivery system, which has a balloon as a portion of it. And then basically we take a large device and we're able to crimp this valve down to...
I just happen to have a crimper.
Well, there you go. We're able to crimp the valve down to the caliber of this blue catheter here, and the valve sits right here, and this whole device is inserted through the groin
A little higher.
up into
there you go. Yeah.
up into the heart. And as the balloon is inflated, the valve is expanded, and the balloon is then deflated, and the valve is left in place.
Let's look at clip 2 because it kind of shows how this is done actually in the cath lab. They're going to pull the valve out now. It's in a solution of some kind.
Right, it's in some formaldehyde or glutaraldehyde. It's a preservative.
And then is that water or what do they put that in?
Yeah, they rinse it in several different preparatory baths just to make sure there's no contaminants or anything on there that we don't want getting into the body.
And I think coming up here we'll show how they crimp it too. Use the tool that you just showed us, Dr. Mischel.
Right. Each one of these bird baths, if you will, kind of dilutes the glutaraldehyde off the preservative off the valve, so that by the time it gets to the body, it's free of any contaminants or any preservatives.
This is a fairly recent procedure too. Up until 2 years ago, this was not being done, was it?
Right. So it became commercially available in about November, December of 2011. We did our first valve in January of 2012, and we're heading north of our 250th valve now.
Wow.
That's
So there's a big demand for this, and it's mostly in elderly people, isn't it?
absolutely. But you know, we're now looking at we're lowering the bar, if you will. We're looking at younger and younger patients, and as we progress with studies, I think we're demonstrating that for many patients, regardless of their age or degree of surgical risk, this is a viable technology.
Now, Nilesh, he's going to crimp that again. Is this going to
Correct.
make it the right size so it can
Yeah,
actually
so
slide
it's
in?
almost like rolling pasta dough. You don't just go to the thinnest dough right away. You get it halfway, and then you crimp a little bit more, and that's what he's done here. So he's made an initial crimp, and now he's crimping it a little tighter on the delivery system.
And like we said, the delivery system is a catheter that's snaked up through the arteries. It's amazing to me that you can get something that size into the heart.
And see, there you see the valve
valve.
crimped on the catheter. The balloon is north of that. Yeah, we need vessels that are about 6 millimeters in diameter to be able to snake this up. Now, there are other ways that we can deliver this to the heart beyond coming up through the groin, but for patients, it's easiest on them if we do it through the groin.
Okay, so we're going to have a little suspense here because we're going to actually show the doctor that performed this, Dr. Goldstein, also one of our team that helps with this program, is going to show us in the cath lab, actually after he gets it on the catheter and ready to go. But we're back to this topic. You say about 2 years ago was when you first. Prairie Heart was a pioneer in this field.
Well, we were one of the first sites to commercially implant the valve, and then more recently, we were a very busy research site in terms of testing new iterations of these valves. And so, beyond what is commercially available, we have several newer type valves which have distinct advantages over the commercially available valves. Nilesh, what are some of the challenges that these newer valves can overcome?
Yeah, I think although they work great, there are some limitations, and I think there's 2 commercially available valves that are now available to hospitals doing this procedure. And probably the main limitation to either one of those is once it gets implanted, it's where it's at, and if you don't like it or if it's not perfect, tough. You know, you're
It's
stuck
there.
with it.
It's there to stay,
and you
huh?
can't. It's hard to move, or they won't move. And so, one of the new valves that we have available under some research, clinical trials, is a valve that you can implant it, evaluate the position, the functioning of the valve, and if you don't like it, you can recapture it, reposition it, and put it back in a different position, all without removing it from the body and all without putting a second valve in. So it is a definite advancement in terms of technology and makes the comfort level of the procedure a little bit easier for us.
I would, if I were you, I would like that option a whole lot. Let's look at the next clip because we can pick up where this. Now here, Dr. Goldstein is describing how they're going to install that.
Right. So now what you see there is that the valve has been crimped onto the catheter, and to the right, by his bloody hand, is the balloon. And what's going to happen is once that catheter gets put into the body, we're going to pull that balloon back onto the valve, and the valve will be essentially seated on the balloon, and that's how it will be delivered into the valve, the old valve itself. Nilesh, you want to pick up the commentary?
Yeah, sure. So this is an introducer that helps us load the stent into the body. And at this point in time, we basically have a long access catheter in the groin, and through that catheter we'll advance this valve system once it's ready.
These valves are very expensive too, aren't they? You certainly don't want to mess one of those up.
Well,
They're
they
really
are expensive. Obviously, you know, it was several hundreds of millions of dollars to bring this to market, and the companies obviously want to recoup their investment, and we're bringing it over to the table here. So this is much more expensive than a surgical valve.
Right.
Also, the effort and labor that goes into production of one of these valves is fairly substantial as well. So these valves are actually sewn by hand onto the stent under a microscope. Wow. And so it is fairly laborious
Safe
just to put
say,
together.
Yeah, your measurement has to be absolutely perfect. And then when you order these, you order them in sizes. I mean, rough sizes, and then you fit them in the cath lab. Is that
right? We make very sophisticated measurements of the size that we're going to need, and then we have for the case we have the sizes that are appropriate. Sometimes we get in there and we've got a size that's too small and we have to go to a larger size, but there are a limited number of sizes available, typically just 4 sizes. So we're usually not left short.
What is he seeing here? They're all looking for something.
They're advancing the valve into the body and waiting till it gets into the mid-chest level, which is right there, and that's when, as Dr. Mischel mentioned, we actually pull the balloon into the stent valve itself.
Now what's happening here is that everything's sort of being aligned, and he's actually pushing the whole system around the aorta into a position very soon to cross the native valve and get this new surgical valve sort of lined up, and everybody's intently staring at the screen.
And that's the fluoroscope that you see.
Correct. So on the left is the fluoro, and on the right is our echo, which isn't really showing a whole lot at this point in time.
They look like he must be getting close to his destination. Would that be
very
about
close.
right?
Yes. Yes.
So some fine measurements here to try to get it in the optimal position. So he takes a picture there with contrast just to align the valve. I think a distinguishing feature of this valve versus a surgical valve is when you have surgery to replace your valve, the surgeon actually removes your valve and sews in a new one. Whereas in this procedure, this stent just pushes or displaces your valve out of the way, and we leave a new one.
And
in
it just
its place.
stays in there?
It stays in there. It
And
actually
that's okay.
anchors.
I mean,
Yeah.
it seems to me like there wouldn't be room for all that in there.
Well, there is room because we've measured it, and then the calcium that's in the old valve, which is rock hard, anchors the stent. And so these don't move; they'll stay there forever.
Wow, that is terrific. So the old valve, does it biodegrade, by the way, or does it just kind of stay where it is
just
going to
stays
stay
there, and it
huh?
gets pushed out of the way,
And it
it's
just gives it something
excluded
to-
by the stent. So it's essentially behind the stent all the way around.
So then the patient, like I said, we're talking about elderly patients because you don't want to. This is going to last them the rest of their lives, right?
Well,
in most cases.
what we call bioprosthetic valves made from biological material, usually a cow, the sac surrounding the cow heart, is used for both surgical and these new TAVR valves. It's the same valve, and you probably only get about 10 to 12 years out of them. So now, if you're in your 80s, 10 to 12 years is a lot of time, and the valve probably will outlive you.
But that could not be removed this way. It would have to be surgical, right? I mean, if this were going to be removed,
No, you can go back inside an old TAVR valve and put in a new TAVR valve.
and just leave the old one there.
Yes.
Wow. And all this metal that I'm seeing here, it remains in there as well, and you just kind of push it back, and that would
But
be.
now remember, when somebody's, I mean, think about it. This was the first generation of surgical valves. I mean, it looks like a toilet seat in a way. I mean, and
it's about as basic
it looks
a
like
plumbing device as you
right.
can.
That's right. It's like a toilet, and this stayed in the heart in the patient forever. You know, it looks like you have a ping pong ball in your chest. In fact, patients would often they could hear the click from the ball coming up and hitting the cage.
Crazy.
It
Every
usually
time your
drives
heart
it
beats?
usually drives the partner crazy.
Yeah, in fact, one of these was recalled because the patients that received them, their suicide rate was double the normal population just from hearing this.
Yeah. I don't even want to think about that. I don't want to think about it. Let's go back to the next clip, because what we're going to see is I think he gets the stent in place, the valve in place, and then he's checking, and you men would know better, but he's checking, he's inflating it now, isn't he?
Yes, you can see the balloon being inflated
On the left screen.
on the left
Correct.
screen.
Pacemaker off. Okay, pacer's going off.
And then as the balloon comes down, the stent stays in its position and the balloon's removed. And the valve starts working immediately.
The valve is functional immediately.
What's the snake that we just saw come into the picture on the left?
So that's a transesophageal probe. So the pictures to the right are from that black
Oh, okay.
probe that you
Okay,
see
and
on the
so
left.
he's looking for what on the transesophageal? What's he looking
Have you ever had that?
One of the other limitation to this valve is it can leak in between the native valve, the original valve, and this new valve. You can actually leak out around the outside. And so that's where sizing is critical, and that's what we all look for immediately after we put the valve in is, do we have much leaking or not? And that helps us determine whether the procedure's over or do we need to touch this valve out a
And
little bit.
how do the colors that are showing up on that monitor, how do they help you determine that?
We don't like to see any color outside the perimeter of the valve.
Okay, that shows you the blood is
Is leaking around.
Flowing around the valve.
And in
We want
fact,
it all to leak, not leak, but go through
in
the
fact,
valve
one of the
itself.
newer things
that looks like the valve right there.
right.
Yeah, that's
and
it.
see how there's no backward filling. And one of the newer things about the next generation valves is that they will have a skirt around the outside of the valve to prevent that leak.
But we're not seeing any leakage.
No,
or you're not
that's-
seeing any leakage
right.
there.
No,
Nothing.
so
And the dye is only on one side of the stent, and that tells you that's the good thing.
That's right. If you saw it going below the stent, then you knew you had a leak.
blood flow, right? Okay.
you want a job?
No, I can't do that. I
See
can't
one, do
that.
one, teach one.
Oh man, I don't have the nerve to do that. I watch you two in the procedures, and it's like I don't think that it ever occurs to you that something might go wrong, but that's all that occurs to me is what's going to go wrong next. You know, what am I going to do? But you guys are so cool. I don't know how you do it, but that's why we're in different professions.
Well, it's lots of practice.
Is that right?
It's like, yes, why are you so good at your job?
Well, nobody ever said that, but
I'm telling you.
thank you. But really, but of course, from a patient's point of view, where does the doctor get all this practice? You know, somebody's got to be the first patient.
And isn't that the most unbelievable thing? Because, typically we will tell patients, listen, you're going to be our first patient. And when we did have a first patient, January 4th, 2012.
For this TAVR procedure.
And people step up. And can you imagine being the first patient?
What was the outcome of that first? Did you perform it?
Yeah,
Okay. What was the outcome?
very good. Very good. Still around.
Is that right?
Yes.
There is fairly rigorous training that goes in to this before the first
Right.
case. So we go away to get trained by whoever the manufacturer of the valve is. You work on simulators. So you're
do
doing
dry runs.
You're doing the procedure several times on a simulator before you actually do it in a live patient. And then there's a lot of support during those initial cases that people that are experienced, have a lot of experience with the valve, that have already done a handful of procedures. They're there right with you walking you through it. So it's fairly supervised.
And I think the other thing is that, you know, what we do when we do these new things are really iterative, meaning it's not so, I mean, it is revolutionary, but it's building on things that we've done before. And so it seems like a small step to us, because it's just building on what we already were doing.
Well, you know, that's one of the things I noticed when I spent that week in your hospital. You all are very comfortable with all of the devices that you have to do. Even if you haven't handled a device before, it's like the device you handled before, right? So it's close enough that you're very familiar. You always feel like you're right where you belong with these.
And I'll tell you another thing in terms of, you know, when you say, well, boy, you always seem so calm about things. I think that's one of the beauty of working in our institution, is that we have a very close collaborative relationship with our surgeons, who are tremendous and talented. And when you work side by side with people who, you know, we get them out of jams, and trust me, they get us out of jams. And when you have that kind of close collaborative relationship, you feel like you can do mostly anything.
Let's take a look at the next clip on this procedure. And keep in mind that as we look at this, we saw that the Dr. Stevens, the surgeon, was in the room with you, and so that's a requirement of these TAVR procedures, isn't it?
Absolutely. In fact, here you see a little close-up now of that valve going in, the balloon going up, and the valve's going to be left behind.
So it starts in that crimped position, very small diameter, and what you're left with is the fully expanded valve.
And here we're going to see the echo. I guess that's called an echo, right?
Yeah, so that's the valve he's pointing out there. And all that bright white stuff is calcium. It's hard like bone. And that's just the sign of a chronically diseased
That was
valve.
before, right?
That's
That was,
before.
okay. And so it looks like it's not opening at all.
Right, it's not moving.
And what are we seeing on the left?
It's just a different view of the same thing, kind of almost 180 degrees the opposite direction.
This is what his valve looked like before. It wasn't letting much blood in or out, was it?
Right.
And you can imagine your heart just straining if you can't eject all the blood, and eventually everything just backs up.
Well, I would think you'd have trouble breathing. Just
Well, that's
enough, just to get enough to breathe.
Right, and that's exactly what those patients complain of, suffocating.
Yeah. Now, what do you've already told us about a new stent valve that's going to be better because you can reposition it. You know, after you think you have it locked into place, you can reposition it. Anything else new coming along in the structural side of this?
Well, in terms of valves, there's now a new valve that we're going to consider as well as in a research trial that doesn't even have a stent. So there's no metal in this valve at all, and so it may be a little bit easier to deliver, less rigid, and maybe even smaller.
What's it made of, if it's not metal?
It's made of Gore-Tex and some rubber balloons. Essentially, the whole valve is one balloon that gets filled with a resin. So it is a truly novel design compared to the other valves that we've evaluated so far.
And what we're talking about here is just the aortic valve.
Correct.
So there are technologies to replace other valves on the horizon, and we even have a technology to repair, for instance, the mitral valve.
And that's, I mean, you can do that now?
Yes.
You can. Okay, what's that called?
It's called the mitral clip. Do you want to
Mitral clip?
The mitral valve is another valve. Instead of 3 leaflets, this valve typically has 2 leaflets. And it connects the upper chamber on the left side to the bottom chamber on the left side. And typically it'll open and then close when the ventricle contracts. In some people, what happens when it closes, instead of kind of closing and make a tight seal, one of the leaflets may flail backwards and it creates a leak. So essentially what's happening there is blood will go right back where it came from, and then the heart has to pump the same blood again. And so those patients can present with heart failure or shortness of breath, just like the aortic valve folks. And now what we have, the mitral clip that Greg mentioned, is a small clip. We can actually come through the valve, and as the valve leaflets come down and are opening and closing this way, I should say, we can clip the 2 leaflets together, and so one doesn't flail out.
It's
and
like a
we
staple.
can control it.
Like a paper clip, maybe. Huh?
It's exactly
Yeah.
what it is,
Yeah.
and prevents the leakage of the
And
valve.
you access that through the groin.
Correct.
And then what's your route? to that?
Well,
valve?
it's a little bit more circuitous route. We actually go up into the right heart, not the left heart, and then we make a puncture across into the left heart and dive down into the valve. So it's a little bit more circuitous route, but just one puncture.
Okay, so the TAVR, the transcatheter aortic valve replacement. Okay,
Correct.
that's the procedure we saw. That allows you to put a new valve in someone that may not be a candidate for open heart surgery, right? In a lot of cases, these are older folks.
Correct.
And in many cases, it's the last valve they'll ever need, because if you're 80 and it's going to last you 10 or 15 years, you're good to go. What about young people? Is there any use for it in young people?
And again, part of our research trials are lowering the age limit. So we are, progressively coming down from 80s to high 70s to low 70s, and maybe even into the 60s at some point in time in the next 5 to 10 years.
Well, it's always, it's got to be easier on you than cracking your chest, right? I mean, I would think almost always, right?
Surgery is a terrific option, and we never discourage patients from having surgery. It's a great option, but typically most patients prefer sort of this cleaner approach if they have that opportunity.
Well, Dr. Nilesh Goswami, thank you so much for coming in.
Thank you.
Structural plumber, and we can add something else to his resume, can't
Plumber,
we?
carpenter, and electrician.
Electrician, okay. And you two, you're trying to be, you want to be electricians in your next life, right? In your next professional life.
The electricians dress better, for sure.
Okay. Thank you, Dr. Mishkel, Dr. Goswami. Thanks both for being here. Thanks for joining us on Cardia, Hearts and Sciences. We'll see you next week.
For a DVD copy of the program you've just seen, send 1995 to Network Knowledge, P.O. Box 6248, Springfield, Illinois 62708. Be sure to include the program name, subject, and when the program aired. You can also order with your credit card by calling 800-232-3605.